Okay, let's dive in. You know that feeling, maybe a sudden kind of unexpected cramp deep in your gut, maybe even noticing a little blood? It can really make you worry, can't it?
It's absolutely.
Today, we're tackling a condition that can cause just that, Ischaemic colitis.
Yeah, that's our focus.
Think of this as your clear guide. We've pulled this from our revision notes, aiming to give you a really solid understanding, but without, all the dense medical jargon.
Exactly. The goal is clarity, those aha moments, not information overload.
So this deep dive is all about ischemic colitis. The sources are those revision notes, so expect a structured, kind of high-yield approach. We'll hit everything from definition to complications.
Right. Our mission, if you like, is to give you that solid foundation so you feel properly informed.
Okay, let's kick off right at the start then.
Yeah.
What exactly are we talking about when we say ischemic colitis?
Well, put simply, it's inflammation and injury to your colon, and it happens because it's just not getting enough blood.
Like a pipe getting blocked somewhere.
Sort of, yeah. Think of it like a plant not getting enough water. It starts to wilt, gets damaged. The cause is reduced blood flow through the mesenteric arteries.
There are mesenteric arteries.
Right.
Those are the main ones supplying the colon.
That's right. They're the key pipeline.
And are certain parts of the colon more, vulnerable?
Yes, definitely. The notes really emphasize the marginal branches of two main arteries. The middle colic, which branches off the superior mesenteric, and the left colic from the inferior mesenteric artery.
Oh.
The spots where their supply networks kind of meet but maybe don't overlap perfectly, those are the weak points.
Ah, like watershed areas.
Exactly like watershed areas,
Mm-hmm.
particularly the transverse and descending colon, often near that bend on the left side, the splenic flexure.
Got it. So a vulnerable junction.
Although there is another sort of backup system, an additional vascular arcade that helps supply that specific segment. It gives it a bit more resilience.
Okay. So what could actually cause that blood flow to drop off?
Good question. The notes point to a couple of main things. One is the colon getting really stretched out, distended, maybe from a blockage further down, or even something called pseudo-obstruction, where it just stops moving properly.
Right.
And the other mechanism is problems with the veins draining the colon venous occlusion. If blood can't get out efficiently, fresh blood flow coming in is hampered.
That makes sense. Okay, definition clear. Now let's shift to the why. What are the underlying causes? The etiology.
Right, the etiology. This is about why the blood flow gets reduced. The notes list several key reasons.
Okay.
First, you've got acute arterial occlusion. That's a sudden, complete blockage in one of the colon's arteries.
Like a clot.
Exactly. It could be a clot, an embolism. Then there's chronic mesenteric ischemia. That's more gradual. A slow reduction in blood flow over time, like a pike slowly narrowing.
Okay, chronic versus acute.
Then vasculitis, inflammation of the blood vessel walls themselves. That can impede flow. Another big one is hypoperfusion during systemic hypotension. So if your overall body blood pressure drops really low, maybe from shock or severe dehydration, the colon might not get its share.
The body prioritizes other organs.
Precisely. And finally, certain medications, vasoconstrictive drugs. Things that make blood vessels clamp down can sometimes trigger it by constricting those vital colonic arteries.
Okay, that gives a good picture of the direct causes. So who's more likely to run into this? What are the risk factors?
Yeah, the risk factors, this is about who's more susceptible. Age is a major one. It's much more common in older adults.
Right.
Having existing cardiovascular disease issues with your heart or blood vessels definitely increases the risk. Low blood pressure, hypotension, that's another factor.
And those vasoconstrictive meds you mentioned.
Yes, they're both a cause and a risk factor. Smoking is on the list too, as it damages blood vessels.
Makes sense.
Having had abdominal surgery in the past can sometimes play a role, and conditions that make blood clots more likely, like thrombosis or embolism. Also, anything reducing the heart's ability to pump effectively decrease cardiac output, certain heart rhythm problems, or arrhythmias.
Wow, quite a few cardiovascular links there. Anything else?
Oh yes, the list in the notes is pretty comprehensive. Severe shock is a big risk factor, whether that's from sepsis, major bleeding, or just severe low blood volume.
Right, that links back to the low blood pressure point.
Exactly. Physical trauma, too.
Yep.
Things like a strangulated hernia or a volvulus where the bowel twists on itself, cutting off its blood supply.
Oh.
Certain inflammatory conditions involving blood vessels, systemic lupus erythematosus, polyarteritis nodosa, sickle cell disease.
Okay.
And even specific blood clotting disorders, deficiencies in protein protein C or S, problems with activated protein C resistance, antithrombin III deficiency.
Gosh, it goes deep into specific conditions.
It does. Interestingly, even things like long-distance running have been linked, though that's less common, and rarely medical procedures like a colonoscopy or barium enema.
Really, procedures designed to look at the colon.
It's rare, but possible, perhaps due to changes in pressure or preparatory measures. Sometimes, though, we just don't find a specific cause that's idiopathic.
Right.
And then there's a list of drugs, things like digitalis, cocaine, vasopressin, some psychotropic and immunosuppressive agents, and major surgeries like cardiac bypass or repairing an aortic dissection.
That is a very long list. It feels hard to keep track of all that. Any way to maybe group them mentally?
Yeah, that's a really good idea. It helps. We could think about, say, things directly affecting blood vessels and flow, cardiovascular disease, low blood pressure, those vasoconstrictive drugs, smoking, clots, vasculitis.
Okay, vessel stuff.
Then things reducing overall blood delivery, low cardiac output, arrhythmias, shock, trauma, maybe even sickle cell affecting oxygen carriage.
Right, systemic issues.
Then procedures, abdominal surgery, colonoscopy, barium enema, underlying conditions, those coagulation disorders, lupus, etc., and maybe lifestyle or substance use, the running, cocaine, and overarching everything is age. Does grouping like that help a bit?
Yes, definitely. That breaks it down nicely.
Yeah.
So fundamentally, pathologically, what's happening inside the colon tissue when the blood flow drops?
Oh.
Pathophysiology.
Right. So the core issue is lack of oxygen reaching the colon tissue hypoxia. This oxygen starvation triggers an inflammatory response.
Okay.
And that inflammation leads to damage, injury to the lining, the mucosa, and potentially deeper layers of the colon wall. And as we said, those watershed areas like near the splenic flexure are often hit hardest because they have the least robust blood supply to begin with.
Got it. So inflammation and damage from lack of oxygen. Now, if someone comes in with these symptoms, the pain, the bleeding, what else might be going on? What are the main differential diagnoses?
Good point. Several other conditions can look similar. The notes mention dysentery, that's an infection, often causing bloody diarrhea.
Okay, infectious cause.
Then acute diverticular disease, or diverticulitis, inflammation of those little pouches in the colon wall that can cause left-sided pain and sometimes bleeding.
Right, very common too.
Also, acute inflammatory bowel disease, a flare-up of Crohn's or ulcerative colitis. They definitely cause inflammation, pain, and bleeding. Acute appendicitis, usually right-sided, but sometimes pain can be less typical.
Yeah.
And something more serious, like a perforation, a hole in the bowel or another organ, or maybe pancreatitis causing peritonitis, inflammation of the abdominal lining, particularly on the left side.
So quite a range from infection to inflammation to more acute surgical emergencies.
Exactly. Grouping them might help again. Infectious like dysentery, inflammatory like diverticulitis or IBD, other acute abdominal pain like appendicitis, or the more severe peritonitis causes.
That helps frame it. Okay, let's talk numbers. How common actually is ischemic colitis, the epidemiology?
Right. Well, the estimates for the UK suggest somewhere between, say, 4 and maybe up to 44 cases per 100,000 people per year. So not incredibly common, but not rare either.
And you said it increases with age.
Yes, significantly. And the incidence, the number of new cases each year, seems to have been rising over time. The notes give figures showing a jump from about 6 cases per 100,000 person years back in the late 70s to nearly 23 per 100,000 in the mid-2000s in the UK.
Wow, that's quite an increase.
It is. It mostly affects older folks. It's pretty rare before 60, often linked to that buildup in the arteries, atherosclerosis. The average age when diagnosed is around 70.
And with populations generally getting older?
Yeah, that's likely contributing to the rise we're seeing. But it's important to remember it can happen in younger people too, sometimes from non-cardiovascular things like cocaine use, as mentioned.
Right, so increasingly relevant. What about the actual experience for the patient, the clinical features? How does it usually present?
It can be quite variable, honestly, from fairly mild symptoms to really severe acute illness. But the classic trio is usually abdominal pain, rectal bleeding, and diarrhea.
Okay.
The tricky part is that these symptoms are pretty nonspecific early on. They can mimic lots of other acute abdomen scenarios.
So how does it typically unfold?
Often, it starts with a pretty sudden onset of abdominal pain, frequently described in the left lower quadrant, the left iliac fossa. Nausea and vomiting can come along with that. Then, a bit later, the person might start having looser bowel movements, often mixed with dark blood or clots.
And on examination?
A key finding is often marked tenderness when the doctor presses on that left iliac fossa area. If there are signs of peritonitis, like the abdomen being rigid or very tender all over, that suggests something more serious is happening, like maybe perforation.
Is there anything about the timing that helps distinguish it?
Yes, the notes highlight the rapid onset symptoms often develop over just a few hours. And if the symptoms worsen alongside signs the patient is becoming generally unwell, like low blood pressure or a fast heart rate, that's a strong pointer towards ischemia.
So, quick onset, worsening picture.
Yeah, it should definitely be on the radar for any patient with unexplained abdominal pain, especially older patients or those with risk factors. And in younger patients, remembering those associations, the pill, cocaine, meth, pseudoephedrine, sickle cell clotting disorders can be crucial.
Okay, so the picture is forming. A doctor suspects it. What investigations get ordered to nail the diagnosis?
Right, the workup. Generally, you're looking at blood tests, maybe a colonoscopy, imaging, and potentially other tests.
What do the blood tests show?
They're helpful for looking for signs of inflammation, like a raised white cell count or inflammatory markers. They also help rule out other things, like severe infection, and check kidney function and electrolytes. Importantly, they might show metabolic acidosis, a sign of tissue distress from lack of oxygen, which can be a big clue.
Okay, and the colonoscopy, you mentioned that earlier.
Yeah. Yes, colonoscopy can be very useful. It allows direct visualization of the colon lining. Findings suggestive of ischemic colitis include seeing a sort of bluish, swollen, boggy mucosa. Often, unlike some inflammatory conditions, it doesn't bleed easily when touched. And frequently, the rectum looks completely normal. The ischemia affects segments further up.
What about imaging, like a simple X-ray?
A plain abdominal X-ray might show an abnormal segment of bowel outlined by gas, maybe looking thickened. But honestly, it's often nonspecific, especially in the first 12 to 18 hours. Not super helpful initially.
Okay. What about a barium enema? Is that still used?
It can be, though CT is often preferred now. But the classic finding on an early barium enema is thumb printing.
Thumb printing.
Yeah, it looks like indentations, like thumbprints, pushing into the contrast-filled colon lumen. It's caused by swelling and bleeding within the bowel wall, the submucosa. That thumbprinting might stick around for days. Later, the barium enema might show the mucosa healing, maybe some ulceration that could mimic Crohn's or ulcerative colitis, or potentially long-term changes like narrowing a stricture or little outpouchings called sacculations.
Any other imaging? CT, MRI.
Yes, CT scans, especially CT angiography, which looks specifically at blood vessels, are very commonly used now. They can show bowel wall thickening, changes in the fat surrounding the colon, and sometimes directly visualize the blood vessel problems. MRI isn't typically first line. Angiography, inserting dye directly into the arteries, is more invasive but can pinpoint blockages.
So key investigation points to remember. Metabolic acidosis on bloods, the visual findings on colonoscopy, X-rays being initially unhelpful, and the classic thumbprinting on barium enema or CT showing wall thickening.
Exactly. Memory tip. Think of that thumbprint literally like swelling inside the wall is pushing inwards.
Right, got it. Okay, we've defined it, looked at causes, risks, mechanisms, differentials, frequencies, symptoms, and investigations. Huge amount covered. How do we actually manage it?
Management strategy depends a lot on severity. It usually involves a mix of supportive care, medical therapy, and sometimes surgery.
What does supportive care entail?
Basically, giving the bowel a rest. So nothing by mouth initially, maybe intravenous fluids to keep the patient hydrated, and good pain control.
Okay, and medical treatment?
For many milder transient cases, just supporting the patient and treating the underlying cause of the hypoperfusion might be enough for it to resolve. Broad-spectrum antibiotics are generally recommended too.
Why antibiotics if it's not primarily an infection?
Good question. It's mainly to prevent bacteria from the damaged gut potentially crossing into the bloodstream and causing sepsis, a secondary infection. The damaged bowel wall is more permeable.
Ah, okay, preventative. When does surgery enter the picture?
Surgery is for the more severe end of the spectrum. If a patient isn't improving after, say, 24 to 48 hours of supportive and medical care, which might be assessed by repeat colonoscopy or CT angiography, then surgery might be needed.
What are the signs things aren't improving?
Things like increasing abdominal tenderness, developing a fever, ongoing significant bleeding, or the bowel shutting down completely, what we call paralytic ileus.
And if there's suspicion of actual bowel death?
Yes, if infarction tissue death is suspected, that's an emergency. Urgent surgery, a laparotomy, is needed to remove the dead segment of colon. So generally, most patients get admitted to hospital, receive supportive care and possibly antibiotics, and surgery is reserved for those who don't improve or show signs of complications like perforation, or infarction.
Okay. What's the overall outlook then, the prognosis, and what are the potential complications?
The prognosis really varies. For mild cases, many people recover completely with no long-term issues.
That's good news.
It is. But for severe cases, the outlook is more guarded. There's a significant risk of serious complications, bowel necrosis, perforation leading to peritonitis, widespread infection, or sepsis. And sadly, the mortality rate is higher in these severe instances.
What influences that outcome?
Several factors. How much of the colon is affected and where, the patient's other underlying health problems, and whether they need an emergency surgery. The notes quote an overall mortality rate of around 22%.
22%. Wow, so it can certainly be very serious.
Absolutely. It underscores the need for prompt recognition and appropriate management.
Okay, so let's try and quickly wrap up the key points from this deep dive. Ischemic colitis. Basically, inflammation and injury to the colon from not enough blood flow. Loads of potential causes and risk factors, especially linked to age and cardiovascular health, but other triggers too.
Right.
It can present in different ways, often with sudden left-sided pain, bleeding, diarrhea. Diagnosis uses blood tests, colonoscopy, imaging like CT.
Yep.
And management ranges from supportive care and antibiotics for milder cases to urgent surgery if there's severe damage or complications. Early recognition is vital.
That sums it up nicely. It really highlights how dependent our organs are on that constant blood supply, doesn't it?
It really does. It makes you think, given that populations are aging, how might the way we manage ischemic colitis need to evolve in the future?
Something to ponder.
An interesting thought.
If you found this useful and want to keep building your medical knowledge, definitely check out PassThem.com and also FreemSROA.com. Lots of great resources there for learning and revision.